Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. Yesterday, we were discussing about the thyrotoxicosis. We learnt about the clinical manifestations and pathology of thyrotoxicosis. Today, let us learn about the investigations, management, and complications of thyrotoxicosis. Investigations. Estimation of thyroid hormones in the blood. So we have seen various clinical manifestations in varied forms. So whenever a patient comes to you with either enlarged thyroid swelling, that is goiter, eye signs, cardiac symptoms, sudden growth spurt in the child, menstrual irregularities, loss of weight, diarrhea, intolerance to heat, preference for cold, anxiety. So in all these conditions, we have to do these investigations. The first investigation we have to do is the estimation of thyroid hormones. In case of thyrotoxicosis, the T4 and T3 are elevated and TSH is suppressed. Some patients will have only elevated T3 levels, then it is called as the T3 thyrotoxicosis. When T4 is normal, T3 is normal, but TSH is low, this we call it as incipient thyrotoxicosis or latent thyrotoxicosis. This is usually seen in the secondary thyrotoxicosis. That means in multinodular goiter and solitary nodular goiter, you see this type of presentation. So this is also considered as thyrotoxicosis, but it is latent. It is going to manifest in few weeks. The second investigation you have to do is the thyroid autoantibodies. This is not to detect the TSH RAB, it is to detect the Hashimoto's disease. Because in early stages of Hashimoto's disease, there will be thyrotoxicosis. So to exclude Hashimoto's disease, you have to do thyroid autoantibodies. Radioactive scanning, it is indicated only in the toxic nodular goiter. Toxic nodular goiter means multinodular goiter with secondary thyrotoxicosis is called as the toxic nodular goiter. You will find a hot nodule in solitary toxic nodule. Hot nodule means where radioactive isotopes are being concentrated to a maximum limit. Then it gives a dense shadow like this. Then it is called as the hot nodule. In toxic nodular goiter, there will be hyperfunctioning thyroid tissue in between the nodules. This is a hot nodule, and here you find the internodular tissue is hyperactive. Why is it so? It is because in multinodular goiter, many of the nodules are degenerated or necrotic nodules. They are non-functional. The internodular tissue is the functional thyroid tissue and it becomes hyperthyroid. Management of thyrotoxicosis. There are three modes of management: medical, surgical, and radioactive iodine therapy. Each method has its advantages, disadvantages, indications, and contraindications. So first of all, let us learn about these three methods, and later, depending upon the patient status, let us choose the proper treatment. Medical treatment. The principle of treatment: Thyrotoxicosis is a disease with remissions and exacerbations, and in many patients it can progress to a natural remission. We have seen that primary thyrotoxicosis is a autoimmune disorder where thyroid antibodies called the TSH-RAB, they are acting on the TSH receptor cells and activating the thyroid gland. Any antigen antibody reaction, initially the organ becomes hypervascular and shows the features of inflammatory reaction. After few years or few months, this antigen antibody reaction will ultimately result in death of tissue or necrosis of the tissue. So whenever the death of follicles are there, they will be replaced by fibrous tissue. Hence, the principle of treatment is to prevent the futures. So that's why what you do is, anyway, the disease is going to burn out. It takes about, in few people, 1.5 to 2 years. In some people, about 3 to 4 years or 5 years. So you wait for 4 or 5 years so that the disease burns itself out. But because of its hypermetabolic and hypersympathetic activity, there may be irreversible damage to the heart and some other organs in the body. To prevent that, what you must do is, you must suppress the thyrotoxicosis till the natural remission is achieved. So you have to give treatment, that means you block the thyroid synthesis in the thyroid gland. Like that, you do it for 1.5 to 2 years. See whether the natural remission is happening. If natural remission is happening, then stop the drugs. So that is the principle of medical treatment. Secondary goiters, that means multinodular and solitary nodule goiters, if they become thyrotoxic, they are not due to the TSH-RAB. They are due to autonomicity. So the thyroid tissue becomes autonomous and it doesn't obey the TSH. It continues to secrete T4 and T3. So that is why you cannot expect a remission here. So these cases, they require some other management, not the medical management. Indications for medical management: children, adolescent, and young adults, pregnant women, mild hyperthyroidism, and for preoperative preparation of the patients. Contraindications: goiter with features of compression. Why it is contraindicated? Why is it contraindicated in goiter with features of compression? Why means with antithyroid drugs, yes, with antithyroid drugs, the size of the goiter increases. Why? Because you are blocking thyroid hormones. So the thyroid hormones get decreased. So with that, TSH will increase. So that will cause hyperplasia and hypertrophy of the gland. That is why whenever you give medical treatment, there is a chance of increase in size of the gland causing compression. Of course, intrathoracic goiter also, for the same reason, you should not prescribe the medical treatment. Procedure of medical treatment: patients should be advised to have physical and mental rest. Mental rest can be given by giving sedatives like diazepam or phenobarbital at bedtime. Patients are advised to have high-calorie, iron-free diet because they are burning out calories and losing weight. That's why you have to advise the patient to have high-calorie diet. Then you give drugs. These drugs are called the anti-thyroid drugs. These drugs act by two mechanisms. Number one, by interfering with the synthesis of thyroid hormones. Number two, by blocking the action of thyroid hormones on the target organs. Propylthiouracil, methimazole, and carbimazole, they belong to the first group. Iodides and iodine also belong to the first group. Beta blockers belong to the second group. That means they block the action of thyroid hormones on the target organs. Because most of the actions of thyroid hormones is mediated through sympathetic system. That means there is hyperactive sympathetic system. So if you block with beta blockers, the target organs are not influenced by thyroid hormones. Calcium supplementation to counter the osteoporosis produced by hyperthyroidism. So this is the method of treatment with medical management. Few details about propylthiouracil and carbimazole. They block the formation of MIT and DIT in the thyroid. Initial dose, carbimazole 10 milligrams 6th hourly. Propylthiouracil 100 milligrams 6th hourly. Methimazole 5 to 10 milligrams per day as a single dose. There will be latent period of 2 to 3 weeks before clinical evidence of improvement. What is the clinical evidence of improvement? Gain in the body weight and reduction in the pulse rate. So these are the two parameters which you must record on every visit of the patient. So it takes about 2 to 3 weeks to achieve the initial improvement. After that, a maintenance dose for 1.5 to 2 years is given. The maintenance dose is of the initial dose. Carbimazole is the favored drug in our country. Side effects of carbimazole: agranulocytosis, increase in the size of the goiter, transmitted goiter in the neonate. So this is the transmitted goiter. The mother was taking anti-thyroid drugs for thyrotoxicosis, and she was born with a child having a goiter. So this is called transmitted goiter. So this is now and then given as a short notes in the examination. Relapse and stoppage of drugs at the end of 2 years is around 20 to 50%. So the disease will be suppressed for 2 to 3 years as long as you give the medicines. Once you stop it, there will be again relapse. It is advisable to supplement 100 to 200 micrograms of thyroxine or 20 micrograms of triiodothyronine 8th hourly to prevent the increase in the size of the goiter, transmitted goiter in the child, and possible hypothyroidism. So this method of treatment is called the block and replace regime. You are blocking the thyroid gland to secrete thyroid hormones, and you are replacing the required amount of thyroxine by external supplementation. So this is called the block and replace regime. So that's why in every case, if you block the thyroid gland and supplement with this thyroxine, that will be beneficial. Iodides, they increase the storage of thyroxine in thyroglobulin and diminish its release by inhibiting the proteolytic enzyme. So when you give large amount of iodine and iodides, they block the proteolytic enzyme in the thyroglobulin. That's why thyroxine hormone is not released from the thyroglobulin and is being stored more in the globulin. Of course, the exact mechanism is not well understood because The iodine and iodates, they are for synthesis of thyroxine. So how can they block? Accidentally, it was observed. When large dose of iodine or iodates are given for thyrotoxicosis patients, the thyroid hormone synthesis was blocked. So that is why they were used. But their effect is only for 2 to 3 weeks. So during this 2 to 3 weeks period, what will happen? There will be increased amounts of thyroglobulin in the thyroid follicles. So because of this increased load of thyroglobulin in thyroid follicles, the vascularity of the thyroid gland diminishes. Because more globulin is there, the gland will become more soft in consistency. It reduces vascularity, it becomes soft and more pliable. So it will be easy to handle this gland during surgical procedure. So when you want to do surgery for a patient with thyrotoxicosis, then what you do is you block the thyrotoxicosis or reduce the thyrotoxicosis by giving antithyroid drugs. Once the thyrotoxicosis is under control, then give iodine or iodates for 15 days. Then what happens? The gland becomes more pliable, less vascular. Then you do surgery. Then surgery will become less troublesome. That means bleeding will be less and surgery dissection can be easily accomplished. Hence, these are used for preoperative preparation in case of thyrotoxicosis and not for the routine management. So for routine management, iodines are not used. Dose: Lugol's iodine 5 minims TID, potassium iodate 30 to 60 milligrams 8th hourly. Then beta blocker drugs, they block the action of thyroid hormones on the end organs. They reduce the sympathetic overactivity. They control the symptoms rapidly, but the size of the gland is not altered. Dose: propranolol 40 milligrams 8th hourly, atenolol 50 milligrams per day as a single dose, or nenolol 160 milligrams once a day. Indications for beta blocker drugs: mild hyperthyroidism, preoperative preparation of thyrotoxic patients. Contraindications: asthma, respiratory obstruction, patients on antidepressants. So that is about medical treatment. So the essence of medical treatment is you give the antithyroid drugs for a period of about 2 to 2.5 years till a natural remission is achieved. After completion of the treatment, if there is relapse, surgery or radioactive treatment is indicated. The principal drugs used in the medical management are propylthiouracil and carbimazole. Methimazole also can be used, but it is sparingly used in our country. Surgical treatment indications: recurrence after antithyroid drugs, retrosternal toxic goiter, toxic nodular goiter. We have seen that toxic nodular goiter cannot achieve remission after antithyroid drugs. They are responsive to antithyroid drugs, but how long you use them, the disease won't burn out. It will be there like that. That is why the preferred treatment is surgical management. Then for cosmetic reason, because a goiter will be there in front of the neck, that will be unsightly. So if the patient doesn't want that swelling, you can do the thyroidectomy. Then side effects to the antithyroid drugs also is an indication for surgical management. Contraindications: recurrence after surgery. Preoperative preparation. Why preoperative preparation is needed? The thyrotoxic patients, if you want to do surgery, you can't do immediately. The reason is they are hypermetabolic. So in a hypermetabolic system, when you give anesthesia, the patient's response will be too drastic. Because some of the anesthetic drugs, they increase the pulse rate. Already patient is having tachycardia. If you are going to increase the pulse rate, that can precipitate in fibrillation. That is why you should first prepare the patient to achieve the normal pulse rate and normal levels of thyroid hormones. Then another fear of not doing surgery without preparation is because when you operate upon a patient with thyrotoxicosis, not only thyroidectomy, any surgery on a thyrotoxicosis patient who is not under control, it may lead to a condition called thyrotoxic storm. Storm. If you guys just blow of wind, you call it just wind. But if there is a big blow of wind, which is uprooting the trees and lifting off the heavy vehicles, then we call it a storm. So same way, suddenly there will be outpouring of thyroid hormones due to a simple stimulus like surgery or trauma. And patients will go into a very hyper metabolic state, which can lead to death of the patient. That is why you should never operate upon a patient with thyrotoxicosis which is not under control. Not only thyroidectomy, even tooth extraction also should not be done. There are many case instances where patients have died in the dental chair with thyrotoxicosis. So you have to prepare the patient. The patient should be brought to the euthyroid status. Surgery on an uncontrolled thyrotoxic patients may lead to thyrotoxic storm or crisis. So what do? You give antithyroid drugs till the patient becomes euthyroid, and later patient is supplemented with iodates for 2 weeks. With the usage of iodates, the thyroid gland becomes less vascular and less friable. Some surgeons don't use iodates in the preoperative preparation because this action of iodates is not uniform in every patient. Some patients they respond to iodates, some patients they do not have any response. That is why some surgeons they do not use iodates at all. They simply straight away go to surgery once the disease or when the thyroxine hormones are brought under control. Before surgery, you do thyroid function test to check that the thyroid hormones are under control. You do indirect laryngoscopy to evaluate the movements of the cords. This is for legal point because there are very many legal cases in the world demanding compensation. Patients undergo thyroidectomy operation. Later they will file a suit telling that their vocal cord on one side is not moving. It may be due to surgical reason, or patient may be having even before surgery also patient may be having loss of vocal cord movement due to some other reason like viral infections in the childhood. That's why you must do a laryngoscopic examination and record it, how the vocal cords are there. Then the surgeon is not going to face a lawsuit. Thyroid antibody test. I-131 scan in multinodular goiter and toxic nodule. It is of no use in primary toxicosis where the uptake by the gland is uniform. Operation procedure. You give general endotracheal anesthesia or local anesthesia in high-risk cases. Surgery. Subtotal thyroidectomy for primary thyrotoxicosis and nodular toxic goiter. Lobectomy, also called as hemithyroidectomy in toxic nodule. Lobectomy means you remove the involved lobe along with the isthmus. Subtotal thyroidectomy, already I told you. You remove the nodular tissue, or in case of primary thyrotoxicosis, you leave behind 10 grams of thyroid tissue in both tracheous epithelial grooves and remove the rest of the thyroid gland, including the isthmus. Complication surgery, hemorrhage, respiratory obstruction due to laryngeal edema, blood clot pressing over the trachea, collapse of soft scabbard trachea. We have seen in large goiters there will be tracheal compression from both sides. That is called the scabbard trachea. Then mediastinal emphysema, bilateral recurrent laryngeal paralysis. So these are the causes of postoperative respiratory obstruction. Then thyroid crisis. Parathyroid insufficiency can be there because when you are doing subtotal thyroidectomy or total thyroidectomy, there is a chance of injuring the parathyroid glands, leading to tetany. And patients may develop late hypothyroidism. Because small remnant is there, that remnant can become again toxic. That's why nowadays many surgeons, what they do is they perform total thyroidectomy. They don't go for subtotal thyroidectomy. They do total thyroidectomy followed by T4 supplementation. I also practice the same thing. For my case of thyrotoxicosis, I do only total thyroidectomy. This is just to illustrate to you the paralysis of vocal cords, how they manifest. Already probably you must have learned in your ENT. This is median position, when both vocal cords are in the midline during phonation. This is paramedian position, which occurs in bilateral recurrent laryngeal nerve paralysis. This is the cadaveric position. That means both recurrent laryngeal nerve and external laryngeal nerve, if they are paralyzed, then this particular position of the cords will be there. This is the position during deep inspiration. So the abduction of the vocal cords varies from paramedian to cadaveric to deep inspiration positions. That is surgical management. Now, the radioiodine treatment. Okay. Okay, recurrence after surgery, the choice of treatment will be either radioiodine treatment or medical treatment. Of course, we will discuss about choice of treatment in various groups after completion of this radioactive iodine treatment. Radioactive iodine treatment, the principle, when radioactive iodine is given, it is absorbed by thyroid gland like iodine. Radioactive iodine, because of the gamma rays, it destroys the thyroid cells due to its radiation. In I-131 scanning, the dose is very little and hence there is no damage to the thyroid gland. In scanning, you give microcuries. For destruction of thyroid gland, you give in millicuries. So the dose will be almost 100 times more in case of therapeutic management. For diagnostic scanning, you give very small dose. Indications for radioactive iodine treatment: primary thyrotoxicosis, toxic nodule, recurrence after surgery, thyrocardiac disease, where the patient is having cardiac failure, then the patient is not fit for surgery. So such cases can be subjected for radioactive iodine treatment. Contraindications: pregnancy. Radioiodine crosses the placental barrier and is secreted in the milk, causing possible detrimental genetic defects. Younger patients. Possible occurrence of carcinoma in later age. If radioactive iodine is given during childhood or young adult, they may develop cancer after 20 years or 25 years. That is why the dose is given after 25 years of age, after complete family. But if you read old textbooks, there is mentioned that the radioactive iodine should be given only after 40 years of age. But recently we have seen a lot of relaxation in the age. It has been observed that giving this radioactive iodine is not going to cause cancer at a later age, at the dose what is given for I-131 treatment. So management of patients with radioactive iodine. The disease is initially controlled with anti-thyroid drugs without thyroxine supplementation, and the drugs are stopped for 14 days, and I-131 is given. If you give anti-thyroid drugs without thyroxine supplementation, what will happen to TSH? What will happen to TSH? If you give anti-thyroid drugs, that means you are blocking the thyroid gland, you are not supplementing with thyroxine. What will happen to TSH? Santi, please think about and then tell me again. You have made a wrong answer. Thyroid is blocked. T4, T3 reduce. So, what will happen to TSH? Yes, it should increase. So, when TSH is increased, what will the thyroid will do in relation to iodine? If TSH is more, what is action on thyroid gland as regard to the iodine entrapment? So the gland will become more avid for iodine. So that is why the patient is treated with anti-thyroid drugs for 14 days. So is treated with anti-thyroid drugs. Once the disease is under control, then drugs are stopped for 14 days. So once you stop the anti-thyroid drugs, what will happen? The trapment of iodine and binding of iodine to thyrosin and synthesis of thyroid hormones will go in the normal process. So why we want all these things? When you give I-131, Whenever you administer I-131, we see that more amount of iodine is absorbed by the thyroid gland. It should trap more iodine. And all this iodine should go into the thyroid follicles, the SNR cells, then into the follicle, into thyroglobulin, where thyroxine is stored. So it should be stored in thyroglobulin. If it's stored in thyroglobulin means then it will emit all its gamma rays and destroy the thyroid follicles. That is our intention. So to make it more trapped and it is stored more in the thyroglobulin, we discontinue the treatment for 14 days. If you are giving antithyroid drugs, what will happen? The antithyroid drugs, they block the iodine trapping, then they block the formation of thyroxine, and they block the storage of thyroxine in the thyroglobulin. So all these things can be avoided. So the gland will become more avid for iodine and it stores more of iodine in form of thyroxine in the follicle cells and as well as in the globulin. So that will cause more destruction of the thyroid gland. So our intention is to make the thyroid destroyed with radioactive iodine. Antithyroid drugs are given after giving I-131 till radioiodine takes its effects, usually for 8 to 12 weeks. After giving radioactive iodine, just like surgery, the thyroid will not melt. It will take about 8 to 12 weeks for it to show its effects. So till that time, patients will be having thyrotoxicosis. That's why what you do is you continue the treatment with antithyroid drugs for 2 to 3 months. After 3 months, you check the thyroid hormones. The thyroid hormones will be markedly reduced. That indicates success of treatment. That means thyroid gland is destroyed. But thyroid hormones are not available to the body. So you supplement with thyroxine. And the thyroxine must be given for life. Dose is 300 to 600 MBQ depending upon the size of the gland. So this is about radioactive iodine treatment. Comparison of treatments, the type of management, indications, contraindications, disadvantages or complications. Antithyroid drugs. Indications less than 40 years or less than 25 years due to, as in the present day books, pregnancy and in mild cases. Contraindications, hypersensitivity, breastfeeding, retrosternal goiter. Disadvantages or complications, high relapse rate, about 20 to 40% the relapse, transmitted goiter, that is to the child, increase in size of the goiter. Subtotal thyroidectomy, indications less than 40 years of age, failed medical treatment, severe disease, large goiters, nodular goiters. Contraindication, previous surgery on the thyroid. Complications, thyroid crisis, transient hypocalcemia, hypoparathyroidism, recurrent laryngeal palsy. I-131 therapy. This I-131 therapy is given in form of liquid. So it will be given in form of drops. So the patient is asked to get 1 glass of fruit juice. So they will add the required dose in form of drops to that fruit juice, and patient is asked to swallow that fruit juice. So the radioactive iodine will go into the stomach, it gets absorbed and it distributes to the body. Thyroid takes up about, normally it takes about 30 to 40% of iodine, but in case of thyrotoxicosis, where its iodine avidity is more, it takes up to 60 to 70% of iodine. So 60 to 70% of iodine is being taken up by the thyroid gland. The remaining will be excreted by the kidneys. So kidneys excrete. So the urine will be having radioactive emissions. That's why the patient should be away from other family members so as to reduce the exposure to the radiation. So the patient should be away from the family members. He should use his own toilet, which should not be used by others because there is a chance of radiation emission from the urine also, whether the iodine gets secreted by the urine. So patient's urine also will be having radioactivity. Indications more than 40 years, but present day indications is more than 25 years if they have their complete family. Complete family means they have their wanted children. Then recurrence after surgery, thyrocardiac patients. Contraindications, pregnancy, and patients less than 40 years of age. Complications, hypothyroidism. So this is a must after giving radioactive iodine. Hence, you must always use the thyroxine supplementation 3 months after radioactive iodine therapy. I hope you understood the various therapeutic methods. Now let us study about the choice of therapeutic agent. Primary thyrotoxicosis. Above 40 years radioactive iodine. Nowadays, patients about 25 years with complete family are given radioiodine therapy. Below 40 years, mild medical treatment, severe or large goiters, surgical treatment. Adolescents and children, medical treatment. So this is the choice of treatment in primary thyrotoxicosis. Secondary toxic nodular goiter. Surgical treatment is ideal as it is less responsive to medical and radioiodine treatment. Toxic nodule, above 40 years radioiodine treatment. Usually the solitary nodules take up I-131 when they become autonomous and hyperfunctioning. Below 45 years, surgery is done as it is easy, certain, rapid, and without morbidity. Recurrent toxicosis after surgery. Above 40 years, radioactive iodine. Below 45 years, medical treatment. Of course, this 45 years, already I told you, present day recommendation is only 25 years with complete family. Pregnancy. So this is very important. This question is given many number of times in general surgery as well as in obstetrics and gynecology. Management of thyrotoxicosis in a pregnant woman. Radioiodine is contraindicated because of the risk to the fetus. Antithyroid drugs cross placental barrier, producing transmitted goiter and hypothyroidism in the child. Supplementation with thyroxine avoids this problem. So whether you have to give 100 micrograms or 200 micrograms or 300 micrograms, that all depends upon the thyroid hormone estimation in the blood. So every month during pregnancy, the patient should come to your clinic for thyroid hormone estimation. You titrate the dose, keeping the TSH, T4, T3 at normal levels. So you have to titrate. That means you have to adjust the dose as per the requirement. Estimation of maternal free thyroid hormones are done every 4 weeks, and smallest dose of antithyroid drugs are used to keep the TFT in normal range. Propylthiouracil is preferred because carbimazole may cause a skin defect in the fetus called aplasia cutis. Usage of antithyroid drugs is beneficial to the fetus as it can block TSH-RAB, which crosses the placenta and causes neonatal thyrotoxicosis. So there is a condition called neonatal thyrotoxicosis. That is because of transmission of this TSH-RAB across the placenta to the fetus, causing this toxicosis in neonates. So this can be avoided or prevented by giving the antithyroid drugs to the mother. The antithyroid drugs are stopped 4 weeks before expected date of delivery to avoid fetal hypothyroidism at the time of maximum development of the brain. The child should not be breastfed after parturition as the drugs are secreted in the milk. Immediately after birth, TFT is done on the child's blood. Surgery carries the risk of miscarriage, especially during first and third trimesters. Hence, surgery or medical treatment with that means antithyroidics with T4 is advised in the second trimester, and medical treatment is a choice for other trimesters. So for first trimester, medical treatment. Second trimester, medical treatment. Or if the goiter is very large or toxicosis is very severe, then you can go for surgery. But anyway, whenever you do surgery, you must always give the patient the risk of miscarriage. Third trimester, again the medical treatment. Management of thyrocardic patient. The cardiac condition should be treated and is managed preferably with radioiodine. If the patient is young, antithyroidics are used and later surgery is done depending upon the condition of the patient. Exophthalmos. Sleeping with head end of the bed elevated to reduce the congestion. Guanethidine, that is sympathetic blocking drugs. So guanethidine eye drops are used to reduce the lid spasm. Methyl cellulose drops to reduce grittiness of the eyes. Why there is grittiness of the eyes? Because of the proptosis. The eyeball is protruding outwards. And there is lid lag and lid retraction. So there is improper closure of the lid. So this produces grittiness. Yes, that can even produce exposure keratitis also. To reduce the grittiness, you can use methyl cellulose drops. In severe cases, you can give prednisolone. Abrupt termination of toxicosis by surgery may aggravate exophthalmos. Hence, it is advised to treat with antithyroid drugs supplemented with thyroxine. Hypothyroidism should be avoided while hyperthyroidism is corrected. Operative treatment of exophthalmos. Lateral torsography is done in severe cases to protect cornea from exposure keratitis. Orbital decompression is done in progressive cases where the above measures fail. So we have seen that myxomatous tissue will deposit in the retroorbital area, causing a lot of congestion to the veins and causing forward pushing of the eyeball. That may cause exposure keratitis, corneal ulceration, destruction of the eyeball. So in such severe exophthalmos or malignant exophthalmos, what you must do is the lateral wall of the orbit, you make a hole there. So then what will happen? All the retroorbital contents, they herniate through this hole outside. So the retroorbital pressure will come down. So this is called the orbital decompression. Thyroid crisis or thyroid storm. Surgery, stress, sepsis, or trauma in an uncontrolled thyrotoxicosis patient will lead to this thyroid storm. Pathogenesis. Whenever these etiological factors are there, they precipitate this particular problem. What will happen? There will be sudden and excess release of thyroid hormones into the blood. Suddenly, large quantities of thyroid hormones will be released from the thyroid gland. This causes three problems. Number one, there will be sudden and excessive sympathetic stimulation. There is sudden increase in metabolic activity, and the adrenal cortex will get exhausted. That means it will be deprived of its contents. So suddenly there will be outpouring of adrenal cortical hormones into the bloodstream. Later, there are no adrenal cortical hormones at all because it will take some time for the adrenal cortex to resynthesize the cortical hormones. So there will be adrenocortical exhaustion. Okay, there is a doubt by Manognya. During pregnancy, if you stop the drugs 4 weeks before expected date of delivery, will it not cause storm during the parturition? Yes, there is a chance. That is why you must always bear the things, weigh the things. So best thing will be to give antithyroid drugs at a low dose so that they will not be, a large amount of antithyroid drugs are not being crossing the placenta. Though it is mentioned in the book like that, but in practice, antithyroids are given till the parturition or even after the parturition also, supplemented with thyroxine. If you give thyroxine, then the problem of the transmitted thyroid goiter in the child will not be there. Anesthesia also is a trigger for the storm. So excessive sympathetic stimulation can lead to tachycardia. Tachycardia leads to cardiac failure. Increased metabolic activity will produce restlessness, excess heat production, and increased demand for oxygen. This excess heat production causes hyperpyrexia and dehydration. Increased demand for oxygen produces tachypnea, dyspnea, and cyanosis. All these conditions can lead to shock. Any one of them can produce shock. But when all of them are there, so it produces a severe shock which may lead to death of the patient. Prevention: any surgery should be avoided in an uncontrolled thyrotoxicosis patient. Treatment: so this is the pathology of storm. So main factors are surgery, stress, and trauma. So these are trigger points. So you must avoid these things. If there is infection or stress, it should be treated. If you plan any surgery, that should be avoided. Then there is sudden and excess release of thyroid hormones into the blood. You block these. You give carbimazole 100 milligrams through Ryle's tube and logolcidine 100 milligrams TID orally or through Ryle's tube. So the patient is comatose, then you pass Ryle's tube and then administer carbimazole 100 milligrams. The usual dose, as initial dose, is the only 10 milligrams 6th hourly. But in case of thyrotoxic storm, you give more than 10 times. Excessive sympathetic stimulation can be blocked by beta blocker, propranolol 40 to 8 milligrams 6th hourly orally or 2 milligrams IV 6th to 8th hourly. Cardiac failure, you give distalis and diuretics. Hyperpyrexia, you give cold sponging and antipyretics. Administer IV fluids and dextrose to counter the dehydration. Restlessness, sedatives. Increased demand for oxygen, administer oxygen. Adenocardialization, you provide the corticosteroids, hydrocodone 100 to 300 milligrams intravenously. So this is how you must manage a patient with thyrotoxicosis. So with that, the shock will be managed. So the same thing, I have put it in another table form. Thyrotoxicosis due to rarer causes. Thyrotoxicosis factitia. Factitia means fictitious. That means it is not real thyrotoxicosis. It is a fiction. What is this fiction here? Thyrotoxicosis due to high dose of thyroxine prescribed by few for reduction of obesity. Some of these obesity clinics, they give some tablets without revealing the name. So these tablets, they contain thyroxine. So with thyroxine, they give high dose. They give around 300 micrograms or 400 micrograms per day. So with these tablets, the patients will get features of toxicosis and they get reduction in the weight. So this is called thyrotoxicosis factitia. Jod-based dose thyrotoxicosis. Already we discussed about this point yesterday. What is this jod-based dose? Yesterday we have discussed about this point. What is jod-based dose? It is iodine-induced goiter. Jod means iodine. Iodine-induced toxicosis is called as the jod-based dose. Yes, in parenchymatous hyperplastic goiters, if you give iodine, so this toxicosis occurs. Then acute or subacute autoimmune thyroiditis. In the early stages of autoimmune thyroiditis, the follicles are disrupted, liberating the thyroid hormones into the blood, causing mild hyperthyroidism. Second is in the bone. Large mass of secondary deposits in the bone from follicular adenocarcinoma of thyroid may rarely cause hyperthyroidism as they are functional. So sometimes the follicular adenocarcinoma of the thyroid may cause deposits in the bone, which can lead to hyperthyroidism. Neonatal thyrotoxicosis, it is due to hyperthyroidism during first 3 to 4 weeks of life due to elevated levels of TSH or EAB, which can cross placental barrier from the thyrotoxic mother. It can be prevented by giving maternal treatment with antithyroid drugs. Then thyrotoxicosis due to TSH secreting tumors, choriocarcinoma, identified mole, embryonal testicular cancer can secrete TSH and that can cause thyrotoxicosis. Stroma of ovary, already I told you, it is a dermoid of the teratoma of the ovary. It is not an ectopic thyroid. Very rarely, hyperthyroidism may develop due to stroma of ovary. So this is about thyrotoxicosis. Any doubts, please? If you have no doubts, we'll proceed to the next topic, that is the thyroid neoplasms. Afshan, please be clear about your doubt. How is total thyroid dependent on protein? What is that? I could not get. Please explain the doubt. Or else I will give access to your mic. You can ask your doubts. Acha, you are talking about estimation of thyroid hormones. Okay. If there is more protein in the proteins, they absorb thyroid hormones. So thyroid hormones circulate in the blood bound to the plasma proteins. So the proteins are more in quantity. So automatically the total thyroid hormones level also will be more because they exert more of thyroid hormones. But amount of them that is released to the tissues will be less. But whenever you estimate the thyroid hormones, you will estimate total thyroid hormones. So that means you estimate the thyroid hormones that are bound to the proteins also. So because the proteins are more in quantity, you will get a false high levels of thyroid hormones. So whenever you do thyroid hormone study, it is preferable in such cases to check the plasma protein total value also. The plasma proteins are normal, then whatever thyroid hormone report you got, it is normal. Otherwise, it is false positive. So, or else you can go for free thyroid hormone estimation. That will always be ideal. Then you can ask me, why can't we do free thyroid hormones in every case? Because it's a little bit costlier. It will almost it is about 3 times the usual testing fees of thyroid hormones, total thyroid hormones. Yes, free T3 and T4 also are there. The total means free T3 and T4 plus protein-bound thyroid hormones. So you'll get the total value. If you are estimating only free thyroid hormones means only those free hormones circulating in the blood only will be taken into account. So we have completed the simple goiter. We have completed the toxic goiter. Now neoplastic goiter. Classification of neoplasms of thyroid, benign and malignant. Benign, follicular adenoma. There is only one benign neoplasm of the thyroid gland, that is the follicular adenoma. But carcinomas, there are 2 types, papillary carcinoma and follicular carcinoma. The counterparts in benign section are only follicular adenoma. There is no papillary adenoma. If by any chance papillary structures are found on histology means it is a carcinoma. It is not a benign tumor. So there is only one benign tumor existing. That is the follicular adenoma. The malignant tumors, primary tumors and secondary tumors. Primary. So there are what types of cells are there in the thyroid gland? All these cells, they can undergo malignancy. Number 1 is the follicular cells. Number 2 is the parafollicular cells. Number 3 is the lymphoid aggregates or lymphocyte aggregates. So tumors can arise from any of these cells. From follicular epithelium, it is differentiated carcinoma. There are 2 types here, papillary carcinoma and follicular carcinoma. Then undifferentiated carcinoma, that is anaplastic carcinoma. Then parafollicular cells or C cells, they produce a carcinoma called medullary carcinoma. From lymphoid cells, there is lymphoma. The secondary tumors, local infiltration from larynx or trachea, metastatic deposits from breast, colon, kidney, bronchus, and melanoma. So from these organs, the tumors can metastasize to the thyroid gland. Follicular adenoma, all benign tumors of thyroid are follicular adenomas. It manifests as a solitary nodule. Clinical features, investigations, and management are same as that for a solitary nodule. So tomorrow we are going to discuss about solitary nodule. So there we will discuss the follicular adenoma also. So follicular adenoma is a type of solitary nodule. The histological differentiation between adenoma and carcinoma is made by a capsular and vascular invasion. Usually, any swelling is there means to know about the pathological nature, the commonly followed procedure is what is the commonly followed procedure? Not only thyroid, anywhere a patient comes to with a swelling. So what is the nature of the swelling? That is, what is the pathology of the swelling? To know that, what investigation you do? You tell me one simple investigation. One simple investigation. Yes, Nizami, you are right. It is FNAC. Yes, it is right. FNAC. So, if a patient with thyroid swelling comes, you do FNAC. By the FNAC, you cannot differentiate between follicular adenoma or follicular carcinoma because their cytological features of both adenoma and carcinoma are almost the same. Why so? It is because this is a very well differentiated tumor. Well differentiated tumor means the resemblance of the malignant cells to the normal cells is almost the same. So you don't see much variation. That means there are no hyperchromatism, there is no pleomorphism, there is no anisocytosis. So you always confuse it for a normal cell. So on FNAC, you can simply say it is a follicular neoplasm. You can't say whether it is a carcinoma or adenoma. So to say whether it is adenoma or carcinoma, you want the specimen. The specimen should be subjected for histopathological examination. In the histopathological examination, if you find capsular or vascular invasion, then you call it as malignancy. If it is not there, you call it as an adenoma. So that is about benign tumors. Benign tumors, there is only one tumor, there is the follicular adenoma. It can be diagnosed only on histological examination, not by FNAC. Malignant tumors. Etiology: radiation of thyroid during childhood, endemic goiter due to prolonged TSH activity, autoimmune thyroiditis. Cases can occur familially, either alone or in association with other syndrome called Gardner syndrome. Relative incidence of primary malignant tumors of thyroid: papillary carcinoma 80%, follicular carcinoma 10%, anaplastic 5%, medullary 2.5, lymphoma 2.5. That means majority of the cases are papillary carcinoma. Follicular carcinoma is only 10%. All the other put together, they are about 10%. First of all, let us study about the differentiated carcinoma thyroid. And already I told you there are two types of differentiated carcinoma thyroid. One is the papillary carcinoma thyroid. The second one is the follicular carcinoma thyroid. The differentiated carcinoma means it is well differentiated tumor. That means its cells have resemblance to the normal cells, but they have tendency for invasion of lymphatics, invasion of bloodstream, invasion of the capsule. Papillary carcinoma: multiple foci may appear in the same lobe or rarely in both lobes due to probably lymphatic spread or multicentric origin. So when you do the cut section of the papillary carcinoma of thyroid gland, you will find multiple deposits. Though patient comes to with a big nodule, but there may be other foci in the other lobe or in the same lobe. There is multifocal origin is there for the papillary carcinoma. Please remember this point. Its origin is multifocal. Though clinically it manifests as a single nodule, there may be other multiple foci in the other lobe. You can see here this patient came to me with a mass in the thyroid gland, this right lobe. So I done total thyroidectomy. Then afterwards, I sectioned the right lobe as well as the left lobe. You can see a mass in the right lobe. This is the one which is clinically evident. Then you see another mass here. There is one more mass in the other lobe. So they were not clinically palpable. So this one only is the palpable one. That means it is multifocal. It spreads mainly by lymphatics, spreads by blood if there is infiltration of the local tissues by the primary tumor. The primary may be small and clinically impalpable, but can cause secondary deposits in the lymph nodes. What do you call this condition? Yesterday I told you. Primary may be occult, but it may cause deposits in the neck, nodes, the lateral part of the neck. What do you call that condition? Occult primary with secondaries in the neck lymph nodes. Okay, that is precocious megadas in general, but very good, very good. Fatima, you're right. Excellent. I appreciate you. That is called lateral aberrant thyroid. Very good. So this woman came to me with this mass in the neck region. It is not moving and swelling. That means it is not a thyroid swelling. When I did FNAC from this, it showed thyroid cells. It is not moving and swallowing. That means it's not thyroid, but histologically it's showing thyroid. That means it is a thyroid deposit in the lymph node. So this is called as the lateral aberrant thyroid. Histologically, papillary structures are present. Sometimes mixed follicular and papillary structure is seen. The characteristic cells are those containing orphan aniide nuclei. You see multiple papillary projections and empty nuclei. High chance of occult metastasis in central compartment nodes is observed, and in many patients, and these will not progress to clinically detectable disease. So there will be usually occult metastasis in the central compartment nodes, that means the pretracheal and delphican nodes. Follicular carcinoma is common in endemic areas of iodine deficiency. Macroscopically may appear encapsulated, but microscopically capsular invasion is present. Multiple foci are rare. Lymph node metastasis is rare. It spreads usually by blood. Carcinoma spreading by blood. There are few other carcinoma which spreads by bloodstream. Can you name them? Carcinoma which has predilection exclusively by blood spread. What are those carcinomas? No, I am talking about carcinoma only, not sarcoma. Carcinomas which spread by blood exclusively. Yes, very good. It is the choriocarcinoma, renal cell carcinoma, and follicular adenocarcinoma thyroid. Very good. Bone secondaries occur in the flat bones of the skull, scapula, and pelvis. Bone secondaries have the thyroid bone secondaries have certain characters. They are osteolytic, functional. They take up iodine and secrete T4 and T3, just like thyroid gland. That is why if a large number of secondaries are there in multiple areas of the bones, the patient may exhibit even thyrotoxicosis because of these secondaries. And they are vascular. They are so vascular that they may be even pulsatile. Hodgkin cell carcinoma. It is a variant of follicular neoplasm. It contains large eosinophilic Ashkenazi or oncocytic cells containing abundant eosinophilic granular cytoplasm with extrinsic nucleus. These are described as altered follicular cells. So the cell of Hodgkin cell carcinoma is Ashkenazi cells or oncocytic cells. So please remember this. This is frequently given in the PG entrance examination. The tumors may be benign or malignant like follicular neoplasm, and differentiation is made only on histological grounds by capsular and vascular invasion. They are commonly bilateral, and metastasis to cervical lymph nodes occur frequently. The tumors carry a worse prognosis with high rate of recurrence and high morbidity and mortality. Clinical features 30 to 50 years of age. So now let's discuss about clinical features of differentiated carcinoma. 30 to 50 years is the age occurrence. It can be seen even in adolescents and old people also. Papillary carcinoma can be seen in patients aged around 15 years also, 1-5. Or it can be seen in 70-year-old individual also. But common age period is 30 to 50 years. Females to males is 4:1. Types of clinical presentation as a solitary nodule, that is the most common presentation, or as a diffuse simple goiter, that is a rare presentation. You can see the photographs of these patients. All these patients have carcinoma. So this is all these are the solitary nodules. So we have seen solitary nodule in some previous conditions also. Tell me, which thyroid diseases manifest as solitary nodules? So we have discussed for the past 3 days. What are they? Tell me. List out all the solitary thyroid nodules. So diseases manifesting as solitary thyroid nodules. What are they? Santhi, you are telling it is simple goiter thyrotoxicosis. What is the definition of simple goiter? What is the definition of simple goiter? What do you call thyrotoxicosis adenoma, Manognya? What do you call thyrotoxicosis due to adenoma? Adenoma of thyroid doesn't produce thyrotoxicosis. That's number one. Number two, thyrotoxicosis can be produced by a solitary nodule goiter. You call this as toxic nodule. So I just list out the diseases of thyroid manifesting as solitary nodule. Number one, the simple goiter, that is the solitary nodular goiter. Number two, follicular adenoma of thyroid. Number three, cyst of thyroid. Number four, Rarely Hashimoto's disease. Whenever you say Hashimoto's disease, you must say rarely, because Hashimoto's disease usually manifests as diffuse goiter, not as solitary nodule goiter. So rarely Hashimoto's disease. And next is this papillary carcinoma, differentiated carcinoma thyroid. Carcinoma thyroid also manifests as solitary nodule. So in these patients, what are the suspicion factors here? Let us see here. Solitary nodules in males. One third of male patients having solitary nodules have carcinoma. That means you must view with high suspicion in male patients. Then solitary nodules in persons with extreme surface, less than 20 years and more than 50 years. You must suspect carcinoma. Then history of radiation during childhood. So this is a male patient with a solitary nodule. It turned out to be malignancy. Actually, this patient came to me for the treatment of his mother. He was sitting in front of me, he's a lecturer, and he's talking to me about his mother. So while he's talking, he was swallowing now and then. So I observed this nodule moving up and down. Then I asked the patient, did you ever get examined for this nodule? He said that no, this is a very small nodule, sir. It is not painful. I don't bother about it. It is not causing any problem. It was there for the past 1 or 2 years. I ignored it. Then I asked him to come by my side and examine it, and found to be a solitary nodule in the thyroid. And then I advised him it is better to be investigated and get it operated. It may turn malignant. Then he viewed with a big suspicion towards me. So he thought that with a bad intention of doing surgery for him, I am tempting him to undergo surgery by telling that, making him scared of carcinoma and telling that words. So immediately he rushed to Hyderabad and he consulted an oncologist. The oncologist did FNAC and they showed papillary process. So he made a diagnosis of papillary carcinoma and advised him to have surgery. Then he ran to me again with those reports and said that, sorry sir, I thought that you are bluffing and then you are unnecessarily provoking me to undergo surgery. But when I consulted this oncologist, he investigated and said that it is this cancer and it should be operated. So because you are the person you first noticed this, I came to you for surgery. So I did surgery, total thyroidectomy, and lesion proved to be papillary carcinoma, and he is safe even today. That means after 25 years. I did surgery about 25 years ago. Still he come every year to me for certain follow-up procedures. So males, you should be very suspicious. Similarly, people with extreme surface, less than 20 and more than 50, you must suspect. So first type of presentation is as solitary nodule. Solitary nodule in males, solitary nodules in extreme surface, solitary nodules in patients who have exposed to radiation during childhood must be suspected of malignancy. The second type of presentation is as a slow-growing mass in the thyroid with features of malignancy. So normally you expect malignancy of the other organs to be rapidly growing. But here, because it's a well-differentiated tumor, the tumor grows for a period of months or years. So for example, this woman is having this mass in the front of the neck for the 3 to 4 years. So when examined, there is hard, irregular, and fixed gland. That means fixed to the trachea, fixed to the prevertebral fascia. So with features of malignancy. What are the features of malignancy for any organ? What are the features of malignancy? There are three features. They are induration, infiltration, involvement. Induration means it feels hard. Infiltration means infiltrates the local tissues. Involvement means involvement of regional lymph nodes and involvement of distant organs by bloodstream. So remember three eyes. Three eyes. So these are the features of malignancy. Induration. The swelling may be hard or irregular. Features of infiltration to the neighboring structures. So what are the neighboring structures that can be infiltrated and what are the symptoms? Tell me, what are the neighboring structures that can be infiltrated by malignant thyroid and what are the symptoms manifesting because of that? As you mentioned about trachea, esophagus, carotid sheath, you have to mention one more structure. What is that one more structure? Nerve. No. Yes, it is a recurrent laryngeal nerve. Yes, it's not vocal cord directly. It is recurrent laryngeal nerve. So infiltration to recurrent laryngeal nerve produces hoarseness of voice. Infiltration to trachea produces cough, stridor, fixity of the gland to the trachea. Infiltration to esophagus produces dysphagia. Infiltration to carotid sheath produces Berry's sign. Already explained the Berry's sign. Infiltration to paravertebral muscles produces immobile fixed mass. Involvement of lymph nodes, that is deep cervical, pretracheal, prelaryngeal, substernal nodes, distant organs by bony secondaries. The third type of orientation is as a mass in the lateral part of the neck due to secondaries in the cervical lymph nodes with an occult primary. So already I discussed this. This is called the lateral aberrant thyroid. Or as a bone secondary without primary. So sometimes follicular carcinoma will have occult primaries. And it comes to you, the patient comes to you with bony mass. You can see here, a patient came to me with a mass in the frontal region. And the histological surprise. When thyroid gland is removed from other diseases like Graves' disease, it may show malignant tumor. So you can see here the osteolytic lesion. Differential diagnosis, you have differentiate this lesion from the other types of solitary nodule goiter, namely adenoma, cyst, simple goiter. From multinodular goiter, if it is diffuse presentation, and Hashimoto's thyroiditis. Investigations, X-ray of the neck for deviation of the trachea, for calcification, indirect laryngoscopy to assess the movements of the vocal cords to evaluate recurrent laryngeal nerve damage. FNAC not helpful in follicular carcinoma, but is very helpful in diagnosing papillary carcinoma. Ultrasound scan. The features of malignancy are irregular halo, punctate calcification. This is very important. The second is hypervascularity, solid mass. Guided aspiration. So ultrasound scan helps for guided aspiration. True cut biopsy. True cut biopsy means with a special needle, you will cut part of the tissue from the thyroid and remove it for biopsy. This needle name is called the true gut needle. So this is done for all the other tumors like breast masses, but this is not done for thyroid because seedling of cells in the tissues and with profuse bleeding, it may cause a lot of bleeding. That's why you don't do true gut biopsy for thyroid lesions. CT or MRI scanning to evaluate local extension if the mass is adherent or shows signs of recurrent laryngeal nerve involvement and presence of tumor invasion and bulky inferiorly located or posterior located lymph nodes. So whenever there are lymph nodes, whenever there is local extension to the trachea, you have to do the CT or MRI scan. It may have also used when ultrasonographic expertise is not available. It is not done in other solitary thyroid nodules. PET scan, it may be useful in case of recurrent cancer with positive tumor markers and negative anatomic imaging. Staging. All patients with differential carcinoma should be staged by TNM staging for risk stratification and for prognosis. T staging. Tx primary cannot be assessed. T0 no evidence of primary. T1 tumor less than 2 centimeters. T2 between 2 and 4 centimeters. T3 there is no extra thyroid spread, lesion is more than 4 centimeters. T4 means any size with extra thyroid spread. That means infiltration of the trachea, recurrent laryngeal nerve, esophagus, etc. The nodes, NX cannot be assessed, N0 no regional lymph node metastasis, N1 regional lymph node metastasis. That means N1A level 6 nodes, that means central group of nodes, N1B any or other levels. Metastasis M0 no metastasis, M plus or M1 is metastasis present. Of course, staging, stage 1, 2, 3, 4A, 4B, 4C, depending upon this table. Of course, this is not required for you as undergraduates. If you know TNM staging, that is sufficient. The treatment depends upon the following factors: whether the lesion presents as a solitary nodule or a diffuse enlargement. What is the usual type of presentation of differential cancer of thyroid? What is the usual presentation? Is it solitary nodule presentation or diffuse enlargement? It's very good. It is solitary presentation. In about more than 80% of the cases, it presents as a solitary swelling. Whether it is a high risk or low risk disease. So in the next slide, I will tell you what is meant by high risk and what is meant by low risk. Clinically or by FNAC proven malignancy. Presence of secondaries. So the treatment depends upon these 4 factors. If the patient presents with diffuse enlargement with clinically or FNAC proven carcinoma. So FNAC shows that it's papillary carcinoma. Then what you do? You do total thyroidectomy. Because there is diffuse enlargement, you remove total thyroid. Then high risk disease. What is meant by high risk disease? Tumors in males more than 40 years of age and in females more than 50 years of age. Tumors larger than 5 centimeters in diameter. Tumors with local or distant metastasis. and extrathyroid spread. So these are called the high-risk diseases. Total thyroidectomy is done in these cases even if it presents as a solitary nodule. So even if a small nodule is there in the thyroid gland, if the patient is more than 40 years, if it's male, or more than 50 if it's a female, or the tumor is more than 5 centimeters, you must go for total thyroidectomy. Then the third type of presentation is solitary nodule presentation in a low risk disease patient presenting without features of malignancy clinically or by FNAC. So FNAC also is negative, presenting as a solitary nodule goiter. So when it's presenting as solitary nodule goiter, solitary nodule in the thyroid, do FNAC. FNAC is negative for malignancy. So negative for malignancy means what do you think? You do ultrasound scan, it is a solid mass. So that means it is not a cyst. So you'll think that it may be a case of simple goiter. So what do you do now for this case? You do treatment for a solitary nodule goiter. What is the treatment for solitary nodule goiter? Tell me. What is the treatment for a solitary nodule goiter? A simple goiter I am telling. What is the treatment for simple solitary nodule goiter? Yes, it is lobectomy, also called as the hemithyroidectomy. So you do first lobectomy or hemithyroidectomy. Then what you do? You send this specimen for histopathological examination. You do biopsy by frozen section or by regular biopsy. Frozen section means you will get the report within 20 minutes or 30 minutes. Regular means the report will come after 48 hours. Then biopsy report is malignant. Then there are three options. Number one, reoperation to remove the other lobe. This is called completion total thyroidectomy. Radio ablation of the other lobe. Suppressive dose of thyroxine. So any of these things, what you are achieving? You are destroying the other lobe. Reoperation to remove the other lobe. Or you give radioactive iodine. That is also destroys the other lobe. Or you give T4 in high dose. That will suppress TSH. When TSH is suppressed, automatically this tumor is TSH dependent. So because the TSH is dependent, the tumor also will regress. And thyroid lobe also, the other lobe also will decrease in size. So if TSH is not there, automatically thyroid gland will involute. So what you are doing here, you are doing a total thyroidectomy or something equivalent to total thyroidectomy. Why you are advised to do this? This is there only as a single nodule. Why you are removing the other lobe also? Tell me. Why do you want to remove the other lobe? Yes, very good. It is because of multiple foci. Why total thyroidectomy? In papillary carcinoma, due to multifocal presentation, the other lobe may have the seedlings of the tumor. That's why you do total thyroidectomy. In follicular carcinoma, there may be bone secondaries. How do you identify these bone secondaries? Again, by radioactive iodine. Now a patient come to you with a mass in the right lobe. The other lobe is there. You have done surgery and removed this right lobe. The report came as follicular adenocarcinoma. Now you are advised to remove the other lobe also, either by surgery, either by radioactive iodine, or by T4 suppression. Why you want to do total thyroidectomy? The reason is you want to detect bone secondaries. How bone secondaries can be detected? By giving radioactive iodine. If you give radioactive iodine for this patient who underwent lobectomy, the other lobe is normal. Whatever radioactive iodine you give, that will be absorbed by this lobe. The secondaries are very small. They are not clinically palpable. You want to detect secondaries which are not clinically palpable. So, when this mass is there, when the thyroid gland is there, it will take up all the iodine and it is not made available for the small secondaries. So the secondaries cannot be detected. It is just like a fight between this sumo and this boy. So the secondaries are like this and thyroid is like this. That's why it absorbs all the thyroid gland. I thought all the iodine. So what you do is you remove this also. Then what will happen? The secondaries are now having no competition. When you administer radioactive iodine scanning, then the secondaries will take up and you will be able to identify these secondaries also. So, papillary and follicular carcinomas, though they are well differentiated tumors, they may have metastasis. To detect those metastases, even though they are occult, to detect those metastases, you have to take away the whole thyroid gland. Then only those secondaries will be manifesting. So this is the reason why you do the total thyroidectomy. And other advantage of doing total thyroidectomy is it can facilitate to monitor the recurrence by estimating thyroglobulin postoperatively. If you do total thyroidectomy, there is no thyroid gland in the body. So there is no thyroglobulin in the body. If you estimate thyroglobulin in the blood, normally you will see some amount. But if you do total thyroidectomy and then estimate the blood for thyroglobulin, the thyroglobulin is negligible or absent. So after doing total thyroidectomy, every year you must check for thyroglobulin. If thyroglobulin is positive, that means are elevated, that means that the fellow is getting recurrence of thyroid cancer. So thyroglobulin is a tumor marker for thyroid carcinoma. So this is possible only if you do total thyroidectomy. If you have done hemithyroidectomy, because other lobe is there, thyroglobulin will be positive. Then if you compare total thyroidectomy versus lobectomy plus T4 suppression, by giving large dose of T4, if you suppress TSH and make the gland involuted, that is okay. But what are the pros and cons? Let us see. The surgeons who favor the total thyroidectomy or suppressive therapy or radioactive ablation have the following reasons. The suppressive therapy will suppress the secondaries also, and radioiodine study cannot detect them to effectively ablate them. If radioablation of other lobe is done, then the patient is not fit to receive another dose of radiation if he develops secondaries in the bones. So for these reasons, the radiation or T4 suppression is not advocated. The patient better choice will be to do surgical total thyroidectomy. But this is not necessary for you. The problems of total thyroidectomy being high incidence of hypoparathyroidism, high incidence of recurrent laryngeal paralysis, these two complications can be avoided by following certain principles in thyroid surgery. The principles in thyroid surgery being, you must do subcapsular dissection of parathyroid glands along with their intact blood supply and keep them aside. That is number one principle in total thyroidectomy. The second principle is, you must expose the recurrent laryngeal nerve in its total course up to its entry into the larynx and safeguard it while you are performing total thyroidectomy. So these two principles, if you follow them, then the chance of injury is almost negligible. At present, many studies have advocated that in low-risk group, I hope you know low-risk group, lobectomy alone will suffice in solitary nodule presentation. That means a lot of cases have been reviewed throughout the world, and it has been found that if the patient belongs to a low-risk group, if it presents as a solitary nodule, lobectomy itself is sufficient. But whatever it is, for your sake, what you must remember is, whenever a patient presents with a solitary nodule in the thyroid gland, FNAC clinical features do not suggest malignancy. What treatment you do? You do lobectomy, subjected for histopath examination. If the report comes as positive for malignancy, as a papillary or follicular carcinoma is present, then treatment must be to reoperate and do total thyroidectomy. You remember that. The other remaining discussion, that is not for you, that's for a postgraduate. So you remember this. If there is associated lymph node metastasis, you do total thyroidectomy plus a therapeutic compartment-oriented neck dissection. That means compartment-oriented neck dissection. That means which compartment is involved with that compartment only you clear the lymph nodes. That is central or lateral compartment dissection depending upon the site of the metastasis in lymph nodes. So if the central group are involved, you remove all the central group of lymph nodes. If lateral side lymph nodes are involved, means the whole lateral side of the neck nodes has to be removed along with their lymphatics. Prophylactic neck dissection is not advocated, though many patients large occult metastasis in the lymph nodes, as they will fail to grow and manifest clinically in low-risk disease. In high-risk disease, prophylactic sentinel node dissection is recommended. If bone secondaries are present, they are detected on I-131 whole body scan after total ablation of the thyroid gland. Already I told you, to identify the secondaries, you must do total thyroidectomy first. So do total thyroidectomy, then you give radioactive iodine, you will find the secondaries. If secondaries are present, then you give radioactive iodine to the patient. For bone secondaries, give radiotherapy for localized or solitary lesions, radioactive iodine therapy for multiple lesions. If trachea is infiltrated, extrathyroid spread of thyroid malignancy means infiltration to any local structure is called the extrathyroid spread. It can be to the recurrent laryngeal nerve, to the trachea, to the carotid sheath, prevertebral fascia. So anything is called as the extrathyroid spread. That means beyond the capsular thyroid gland. That's all. So if trachea is infiltrated, do total thyroidectomy plus resection of the tracheal rings along with primary reconstruction of the trachea. I hope you are a little bit confused, so I will give summary. Differentiated carcinoma of thyroid. There are 4 things to be considered. Is it diffuse or solitary lesion? Is it high risk or low risk disease? Local infiltration present, secondary is present. Diffuse, treatment is total thyroidectomy. Solitary, do lobectomy. Convert it to total thyroidectomy by surgery or by I-131 radiation or by T4 suppressive therapy. Risk factor presence, total thyroidectomy. Local infiltration, excision of tracheal rings and reconstruction of trachea. Second is in the bone. In the lymph nodes, remove the lymph nodes which are enlarged, or you do modified neck dissection. That means the compartment which is involved with the lymph nodes, that compartment has to be removed. That means either you do central node dissection or lateral neck dissection. Bone secondaries, do I-131 scan followed by local radiotherapy. If it is a single secondary, you I-131 therapy if there are multiple secondaries. Adjuvant treatment, radioiodine. After 3 to 4 weeks following total thyroidectomy, radioactive iodine scanning is done. When TSH levels are at highest level and remaining thyroid tissue, if any, is iodine avid, to scan for thyroid tissue in the whole body. So our aim is, after doing total thyroidectomy, to check whether the whole thyroid gland is removed or not, because small pieces of thyroid gland will be stuck to the trachea while you are dissecting it from the trachea. They will become again active and they may become malignant. And there may be deposits in the lymph nodes, small microscopic deposits. They are not clinically palpable. During surgery also they are not palpable, but they house a microscopic focus in the lymph nodes. So how to detect them? That is what you do is, first you do total thyroidectomy. Wait for 4 weeks. So after total thyroidectomy, the patient is in state of hypothyroidism because you have removed the thyroid gland. Because he is having hypothyroidism, what will happen? The TSH is more. So under the influence of TSH, if any remaining thyroid tissue is there or lymph nodes are having the thyroid focus, they will now become more iodine avid. So after 3 to 4 weeks time, you do radioactive scanning. Because they are iodine avid, they will take up about 70% of iodine. So in the scanning, you will be able to make them out. So you can make out the foci in the lymph nodes as well as the foci in the tracheal bed. If the scanning shows residual thyroid tissue, ablation dose of radioiodine is given. You give a large dose of iodine to ablate all those small foci. In old individuals and multiple recurrent disease, the thyroid loses its iodine avidity, and in such cases, external radiation is given. Multiple doses are given till any remaining thyroid tissue is completely ablated. Thyroxine. In low risk group, maintenance therapy with TSH at physiological levels is recommended at present. Post-operatively, the patient should be given adjuvant thyroxine therapy. Because you are doing total thyroidectomy, there is no thyroid secretion. So you give thyroid supplementation. In high-risk patients, you given as a suppressive therapy. What is suppressive therapy? It is suppressing the TSH. So the TSH is normally 5 milliunits per liter. That is normal. So you give thyroxine in such a dose that TSH levels are less than 0.1. That means you give a high dose of thyroxine. Your intention is to block the TSH because the tumors are TSH dependent tumors. If you block the TSH, the tumor will never regrow. That means the chance of recurrence will be almost negligible. The side effects of long-term suppressive therapy and osteoporosis and cardiac arrhythmias. Then thyroglobulin measurement. It is of value in post-operative follow-up to identify the recurrence. It is elevated in metastatic disease or recurrence. This is not required. So the parameters to be followed up after treatment of differentiated cancer thyroid are TSH estimation every year. Ideal level is 1 milliunits per ml. Clinical and ultrasound examination once in 6 months for any recurrence in the thyroid bed and for metastatic nodes. Thyroglobulin estimation. If it is undetectable, it signifies low risk disease without recurrence. And if it is elevated, serial estimations to be done for rising titers. If the titers are rising, radiation therapy is indicated. Prognosis is done by scoring by different methods, but this is not required. For low risk group, 25 survival is 98%. 90% of the patients belong to low risk group. High risk group, 25-year survival is about 55%. So here thyroid cancer, differential cancer, we give the survival rate for years, 25 years, not 5 years. For breast cancer, we measure in 5-year survival rate. But here we measure in 25-year survival rate. Why? Because once you remove this disease, you can forget about the disease. This gives such a very good prognosis. You can say 98% of people survive for 25 years. Hutchinson cell tumors, a variety of follicular neoplasm, are more malignant. Follicular carcinoma carries twice the mortality rate of papillary carcinoma. So this is about differentiated carcinoma of the thyroid. So the treatment is a little bit more heavy for you now. So what you do is, I will stop the class now. You read the topic again, and if you have any doubts, feel free to ask me tomorrow. So tomorrow we will discuss about the remaining topics of the neoplasms of thyroid, then Hashimoto's thyroiditis, then we will go to the discussion of solitary thyroid nodule. We have seen various diseases manifesting as solitary nodule. So put all of them put together. If a patient comes to you with a single swelling in the thyroid gland, so how it manifests and what are the things we have to suspect, how to investigate, and what is the management. So those things we will discuss tomorrow. Any doubts? Please read these topics as they are finished. So please read the thyrotoxicosis and neoplasms today itself. Because day after tomorrow, we are going to have a complete session on case taking, case presentation. I will show you number of cases. First of all, I will discuss about how to examine a case of thyroid, how to arrive at the diagnosis. Then I will show you about some 6 or 7 cases of thyroid swelling. You must tell me the diagnosis and the management. All of you, not the 3 or 4 who are commonly presenting. So all of you should participate in the discussion. Or else I will have the list of your names by my side and I will ask by name, what is your diagnosis? What is the treatment you give? Like that, I will ask the questions to you. Okay? So all of you be ready with this topic, that is day after tomorrow. Okay, see you tomorrow. Thank you. Wish you all good night.